It's very nice to see everyone today. Welcome to Partners in Pain. My name's Cathy Jeffreys, and I'll be your facilitator for today's session. It's a real honor, and thank you so much for joining us. As we gather here today, and before we begin, it's important that we offer a land acknowledgement and acknowledge that we are all on treaty land. I'm joining you today from Saskatchewan, which is Treaty 6 territory. And we pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Just a tiny bit of background, and some of you may have heard this. Partners in Pain grew out of the Improving Pain in Saskatchewan Collaborative Research Project, led by our very own Dr. Susan Tupper, who you'll see there. The research project aims to give pain a voice by bringing people together to share information and plan action to improve how pain is managed in the province. The research project led to our first pilot series of Partners in Pain webinars in March 2020. Pardon me. The feedback from the pilot was very positive and led the research team to seek additional funding to help support the continuation of the webinars. Partners in Pain received a Community Initiatives Fund Community Grant in mid-2021 for an additional series of webinars, which is what brings us here today. And all this work is supported by Sask Pain, a nonprofit organization which is on a mission to help improve the lives of those living with pain in Saskatchewan. If you haven't had a chance, you can check out the website saskpain.ca. So just a few webinar etiquette points here, a few reminders before I introduce our first speaker. Please keep yourself muted while our presenter is speaking. That helps minimize the background noise. And we're certainly happy to see everyone's faces, so feel free to keep your video on. But if you're having a connection issue, it may help to turn your video off. And there'll be an opportunity to ask questions during the session. So please submit your questions in the chat box, and I'll be sure to share them with our presenters going forward here. Now, I want to bring your attention to the bottom of your screen where it says chat. If you can click on that, that's where you put your questions in. And Susan has said that Dana's asked her to say hello. She's not able to attend today because she's having a day with a migraine. So that's too bad. We will certainly miss her today. So without further delay, because now I'm starting to ramble, it's my great pleasure to introduce you to our first speaker today, Bree Rutten. Give us a wave there, Bree. And Bree graduated from the University of Saskatchewan with a degree in physical education in 1998, followed by a degree in physical therapy in 2001. Since graduation, Bree has focused on the treatment of pelvic disorders, with advanced training focusing on concerns of the bladder and bowel, pregnancy, and pelvic pain. Currently, Bree works in the area of chronic pain at the MAC IOPS program, which is now called the USAS Chronic Pain Clinic. The focus of her treatment is on creating balance and strength to create a strong base for everyday life activities and fitness. This applies to anyone of any age, gender, or activity level. In addition to clinical treatment, Bree also participates in workshops, conferences, and speaks to groups to provide education on pelvic and core function throughout the province. And so I will put myself on mute and thank Bree for starting her presentation.
Okay, here we go. Can everybody hear me okay? Great, thank you. Hi, thank you for having me today. I love to talk about this topic because it's what I do. I'm going to try to be very mindful of the time. Now that my slideshow is up, here, I'm going to put my phone down so I can actually watch, because as Cathy was suggesting with herself, I can ramble all day about this. I have gone over this presentation several times, and I've taken out and added in and tweaked it. So here's the reality of it, I think, is pelvic pain is A, not well understood, and B, sometimes there aren't great treatment options for it. And I always talk about the pelvis being a big puzzle, and there's so many pieces to the puzzle that we have to talk about. So I was trying to keep my puzzle little for what we're talking about today. And certainly as questions are coming in and we hit the question and answer portion of it, we'll discuss things more in detail as we need. So I'm going to give kind of a broad overview of what the heck is pelvic pain and what can physio do, and then we'll kind of dive into more things specifically as needed. So, I should mention, yes, I am currently at the MAC IOPS program at the university, which is just transitioning, as Cathy mentioned, into being called the USask Chronic Pain Clinic. So there's 2 of us physiotherapists there. It's a multidisciplinary program with pharmacy, social work, and physiotherapy for an approach to treating chronic pain. Let's talk about pelvic pain. So what is pelvic pain? Pelvic pain means that there's pain within the pelvis, internally, or on the outer layers of the pelvis. So when I talk about pelvic pain, I often talk about 2 different layers to the pelvis, the outside layer of the pelvis and then the inside layer. So we're going to break down those 2 pieces, and then we'll talk a little bit about what we can do about it. So what is the outer pelvis? These are the groups of muscles that work as a team to kind of help support the pelvis and the spine. So when I think about outer pelvis, I think hips and legs, and then I think spine comes out the top of the pelvis. So that would include these muscles that I've included here. Lower abdominals, core, we'll use that term very loosely, glutes, which are your big bum muscles at the back, inner thigh muscles, your spine muscles, and then your pelvic floor is a piece of that, but we'll talk about it as kind of its own component in a second. So I will say, I think for years that we didn't really take into account enough of this outer pelvis stuff when we talked about pelvic pain. Lots of times we focused right in on the pelvic floor and the inner pelvis, and we kind of forgot that we have to teach these things how to coordinate really well. These are the muscles, like I say, that create movement for us, and they need to really learn to work as a new system as we're retraining the pelvis. So here's just a slide that shows a lot of these outer muscles and where they attach in relation to the pelvis. So the first picture is looking from the backside of the pelvis with some of the deep hip muscles. It says piriformis, glute minimus. That's the deep hip muscles from the backside. The second picture in the middle is looking straight on into the pelvis and the spine from the front. So that shows some of the muscles that wrap around from the spine and connect into the hip area. Those inner thigh muscles are the big, flat, wide ones from the bottom coming up to attach into the pelvic area. And then the last picture is your glute max and glute med, which are kind of the bigger glute muscles from the back of the pelvis that I was referring to earlier. So when I think about outer pelvis, as far as physio goes, with thinking about bones and muscles and movement, these are the outer pelvis muscles that I really focus on. So then what the heck is the pelvic floor? I think pelvic floor is talked a lot about these days, but it's hard to kind of get a sense of what we're talking about until you can actually have a visual of it. So the pelvic floor muscles are the muscles that are underneath our pelvis. They serve a couple of very important functions. The first function is that they help support our bladder, our uterus for female pelvis, and rectum. So they come from underneath and scoop around like a hammock. Their job is to help close off openings and to help support things. Here's a female pelvic floor. So this is a side view, looking at somebody sideways. You can see at the back is the spine. The bottom of your spine is your tailbone. So when I think about the pelvic floor, your anchor in the back of your pelvic floor would be your tailbone. Your pelvic floor then is a sling that comes up to the front, which is your pubic bone at the front of your body. So that hammock is what supports those organs inside of our body. Female pelvis. A question I get all the time is, well, do men have a pelvic floor? Well, they sure as heck do. And we're going to talk about that as well. So same function, same attachment points. It comes off the tailbone, swoops to the front, to the pubic bone at the front. The major difference, obviously, in a female versus a male pelvis is that female pelvic floor has an opening, a vaginal opening, which, when there's an open space, is a potential area for pressure or strain to go through. So sometimes when we're talking about pain, we also talk about pressure and where might there be pressure felt, which for either pelvic floor could be just general pressure through that hammock area. It could be lower abdominal. It can kind of be through any of those areas that might have a weakness in it. So what happens when we have pain in a muscle? Any muscle in our body is the exact same as our pelvic muscles. If we have pain, they want to protect you. So their natural reaction is to guard and just freeze to try to provide protection. So there might be spasm and tightening up. There might be some swelling in the area. And then as one muscle gets tight, we saw all those outer layers and other layers, they start to get pulled into it. And then even though it might have started in one little muscle group, suddenly there's a lot of muscles that are trying to help support and protect. And it's okay for a muscle to do that for short-term pain relief. But when these muscles are irritable and tight for long periods of time, they forget what they're supposed to do in life. And their new life is about being tight. Tight is not strong. So when a muscle is tight, we have to figure out how to retrain it to work like it needs to work. So, like I say, as things get tighter, we get more irritation. That's going to make things even more tight because it's trying to protect itself, and then it gets more irritable. And then we get, I say, a big snowball. So what we have to do is figure out where can we disrupt that snowball so we can start to retrain things. So when I think about pelvic floor, I'm checking my time. Oh, I'm doing good so far. Pelvic floor specifically, inner pelvis. These are some of the questions and things that I talk about with people that I see. Kind of the basic, big picture, I'll say for the inner pelvis, are the organs that sit within our pelvis, which is our bladder and our bowel. And for, again, female pelvic floor, we might be looking at uterus. So if there's bladder concerns, is there a lot of urgency? Do people feel like they have to pee all the time? Do they feel like they fully empty or not? Might be having leakage from their bladder. Those give me little hints as to what might be happening with a pelvic floor that might be a little bit tight and grippy and not knowing how to relax, or a pelvic floor that's actually weak. And a weak pelvic floor isn't giving us much core support either. So if there's weakness, we could actually have pain because our pelvis doesn't have enough support. Same thing with the bowel. People might have a lot of urgency with their bowel. They feel like they can't get to the bathroom on time. They feel like they are going all the time. They might have leakage. Pain, obviously, is a big factor in pelvic pain in general. And again, difficulty emptying. If it's female pelvis or somebody that's come to me, say, after they've had a labor and delivery, we might be looking at what happened hormonally, for sure, in that instance, but also what happened with how was their pregnancy, how was labor and delivery, what kind of trauma might there have been associated with that. For those that menstruate, we'll talk about hormone changes with that. How regular are their cycles? How heavy are they? How crampy are they? Or what types of hormone control has there been attempted? So if they've been on birth control, what types has it helped? Or sometimes not at all. When I think about pain specifically, inside pelvic floor pain or outer pelvis pain, these are the big factors that I look for. So location, where exactly is your pain? And sometimes there's a broad area of pain. Sometimes pain is here one day and then the next day it's over here. So I want to get a sense of where is it and what affects it. So what makes it worse? What is aggravating? Is there movement? Are hormone changes aggravating? How is sex? Here's my thing. I think in general, we don't talk about this stuff enough. We don't talk about what is normal for our bladder, what is normal for our bowel, how is sex. So you go through life a lot just knowing what you know, which might not exactly be ideal for us. So I talk about all this stuff all the time. Comes up a lot. And I think we have to be comfortable talking about these things. Relieving. So what actually helps your pain? Are there certain positions you get into, stretches? Do you need heat or cold? Are there medications that help or not? So that, again, it gives me a sense which road we're heading down to try to find more solutions for it. Other injuries. So, when people first come into my office, my question to them is, tell me what brought you here today. Some have a very specific purpose and others say, I just had pain for years, or, my back is sore all the time, but it's okay. No, it's not okay. And why does it hurt? Because that's probably one of those pieces to the puzzle that I mentioned at the start. So if there's been hip injuries, spine injuries, pelvic injuries of some sort, I want to know about that because it's probably a piece of the puzzle. And trauma. We know these days that we have a lot of trauma in our lives. It might be physical trauma, like we just mentioned. It might be emotional trauma. And we store stuff in our bodies and we push things down and we just keep on trucking through life sometimes. And we need to figure out ways to release things that are held in our body, whether it's physical pain, emotional pain, so that we can help retrain our body and how our body is reacting to life. So there might be physical therapy treatment for the pelvic floor specifically. There might not be, depending on what I find. Regardless of whether it's inside pelvic pain or outside pelvic pain, we have to figure out how to control the muscles in a better way. So if they've been stuck for too long, or if they're weak and they don't know what to do, we have to teach them what their new job is. So I need to know that things can be strong. I need to know that things will relax. It has to be controlled. So I might do a pelvic exam so that we can figure out where spots are that need to be worked on. I might not, depending on what I find. So there might be specific exercises catered towards that, of take a muscle that's stuck and let's give it a job to do. I think for years we talked about not overdoing exercise. And I'm certainly not anybody that pushes too much, because I'm not here to put you into more pain. But I do think sometimes if a muscle is stuck, we actually have to give it a job to do, or it's going to stay stuck, because that's what it thinks is normal. So if a muscle is stuck, I very often will give just some gentle exercises to squeeze the muscle a little more, kind of pop it out of that stuck state, and then I can get it to relax. Once it's relaxed, then we can work on strength and off we go. But you can't strengthen a muscle that's stuck. It's just stuck. Sometimes I pull in other health professionals to help assist us in this. So we might talk about if you have massage or acupuncture or naturopath or dietitian or who else is on board, to make sure that we have this big team approach when we're running through this journey together. Here's the thing. I think life is about moving, and I have a really hard time telling people if there's an activity they love or a hobby they love to do, to stop doing it because it might flare them up. Because here's what I've learned. When you say don't do it, at some point, if they love it, they're going to do it. So how about I help them get there in a better way? So I look at core strength and stability. If we need to look at specific training for, say, a sport they want to get back to, or a certain task they want to do when it's almost spring, knock on wood, like it is here, we want to get out gardening, maybe I have to work on how well they can squat down to the ground and stand up again if they're lifting and carrying things. So I'm very focused on life for them, because everybody's got a different life. So let's make sure we're training them for what they need in their life. So I start pretty focused. I get very specific at the start, and then I start to grow and add more things to the picture to get them back to the activities they want to do. We need to mix things up. I don't think ever just about strengthening and stretching exercises. It's just about moving your body in a way that feels really good. Here's my biggest thing I say every day of my life with my patients: life is about moving. So I just need to know what you want to do in life for movement, and that's where I want to get you to. And we have to figure out how to teach your body that movement can be a good thing, and that we're not always challenging and pushing it, because you've pushed through enough in your life with chronic and persistent pain. And sometimes it's about just taking a step back and encouraging something in a different way and thinking outside the box. So it's nice when our body wants to move and that we don't feel like we're always forcing it to move. Okay, how did I do? Oh, okay, so thumbs up from Cathy. Cathy, do we want to do questions now?
If it's okay with you, is it okay if we continue on with your presentation and do the questions at the end?
I'm good. I'm done my piece. So do we want?
Oh, okay. Sure.
Yeah, I'm happy to do whatever.
Okay, so you're done your presentation.
I'm done my portion.
Okay. And were you going to do a piece on the chronic pain clinic, or?
Oh, I can talk about the chronic pain clinic. I didn't want to toot our horn if this wasn't the time to toot the horn.
Because we can let you finish, Bree, and then we can go into the questions if that's okay.
Okay, yeah. So our chronic pain, the USask Chronic Pain Clinic, which, like I say, the name is just transitioning, is a chronic pain clinic that's run through the College of Pharmacy at the University of Saskatchewan. We're in the Health Sciences building, and it's been in existence for 2 years now. It was initially started by a group of pharmacists who were trying to find ways to help people with chronic pain deal with medications that might help their pain in a better way, or that maybe they could look at medications and how they could make them more useful with perhaps less side effects or different interactions with them. When we think about our program, we think about the 3 M's, we call it. So there's the mind. So we have medical social workers to help with strategies for dealing with pain in a different way. That's the mind piece. There's the movement piece, which is physical therapy. So there's 2 of us physical therapists there. And there's the medication piece, the pharmacists. So to access our program, you can self-refer to the program. On the website, there's a button where you can click to put in your own paperwork, or any doctor, nurse practitioner, physiotherapist, health professional could refer you as well. Once you're referred to the program, you have a pretty decent intake package to complete, which is, I want to say, hit or miss 16-ish pages, so that we have a really good idea of what's happening with your pain, where you're at with it, and kind of what your goals are from coming to the program and what you're looking for. So the important thing about the program is that the three health professions work as a team. The physiotherapist, this medical social worker, and the pharmacist. So when you come into the program, all three of us will see you during the first assessment. Assessments are always virtual at the start. And then we take you through the program, which is not a short-term program, but it's about a 6-month plus or minus program to see if we can make some changes as far as chronic pain goes. Great program, obviously. I love it. I'm a part of it. And the nice thing is we have a lot of resources. So they run support groups. We're looking at starting up a walking group for people so that we're building a little community of support through the program as well. And if there's any questions about the program, I'm happy to answer them as well.
That's excellent. Thank you so much for that overview. And Bree, I see there's a question in the chat, but I just wanted to first say, well, thank you so much for your presentation. And I really appreciate the approach that you described, which is an interprofessional or team approach, because I think with my background in nursing, that continuity care is so important, and pulling in the team that the person needs at the time. And I also really like your comment about if somebody likes, if they want to play hockey, they're going to play hockey. So you help them learn how to play hockey so that they're comfortable doing that. So you learn, you get to know the person, you work with them, and then you work with them in terms of where they're at so that you can help them have that quality. So I really appreciate that approach as just a person, and then as a fellow healthcare provider. So
I think we go through life, and at the start, coming out of school, we're very motivated. We're going to fix everybody. And to be honest, you flare up a lot of people and you learn what not to do, and you learn. But I just think, there's maybe activities that aren't the best for our body. And again, maybe you can tweak them a bit, but I really want people to find joy in their life with what they want to be able to do. And, lots of times we can move towards that goal if we just break things down a little bit and learn how to move in a better way. Yeah, I appreciate that. Thanks, Cathy.
Yeah. And I would imagine that your approach, we'll hear more from Laura about this in a few minutes, but your approach also helps people learn how to, or empowers them to self-advocate.
100%. And, that's the reason I took this job at this clinic. I've worked in the area of the pelvis for, sadly, 21 years. I feel like I'm not that old, you guys, but here we are. And I think, there's a lot of frustration dealing with persistent pain and trying to get answers. And when I'm one health professional on my own, never mind a patient that's trying to find resources, it can be so, so frustrating. So I loved the idea of this clinic and was thrilled that I got to join it.
There is a question in the chat: can sciatica be related to pelvic pain?
100% it can be. So, okay, wait, disclaimer. I'm not saying every case of sciatica involves a pelvic floor problem, but if that picture that I showed with all the muscles of the back of the pelvis, the first picture showed the piriformis muscle. So your piriformis muscle comes off your hip and attaches back to the back of your sacrum. Lots of times sciatica pain comes from that little piriformis muscle getting a bit tight and pinching on the sciatic nerve. In my world, I think the piriformis is part of your pelvic floor. If I was to go from deep pelvic floor muscle, being the deepest layer, next layer out, piriformis and hip muscles. So lots of times there's a correlation, and it might not start like that. Here's the thing I always say: which is the chicken and which is the egg? Who knows? But at some point, especially if you've been dealing with sciatica that hasn't resolved with stretching, exercises, chiro, massage, that kind of thing, I think maybe that's a little factor that hasn't been looked into yet and that we need to consider. Absolutely.
So are you saying then that it's not just a nerve problem, it can also be a muscle problem, and you have to have two separate treatments?
Absolutely. Yeah. Yeah.
Okay. I never thought of it quite that way, but that's a way to look at it.
Mm-hmm.
You gave us a good overview sort of the picture of pelvic pain and possible causes. Have you noticed in your practice anything related to age or age of person or etc.?
Mm. So one of the biggest factors in the pelvic floor, let me be a little more specific this time, if we zoom in on it, is hormone levels, because hormones feed the pelvis. They come in that area. Muscles and tissues, I'll say, within the pelvis are very hormone dependent. So typically when we have good hormone levels, which again varies person to person, things have a lot of support, stability. It's a happy pelvis when there's good hormone level in it. So the classic times I see people for pelvic pain are when hormones change. So there's an influx of hormones or there's a loss of hormones. It doesn't always mean that if your hormones are high, you're going to have pelvic pain, but it's often when there's a flux in them that the pelvis is kind of struggling to figure out how to adapt to those changes. And that's a common time that we see, which obviously as we age, our hormones change.
That's interesting because Gail just put a question in, can Bree speak to the use of estrogen in relationship to pelvic pain?
Yeah. Very good question. So if we talk about estrogen specifically, typically as estrogen decreases, that's when we have less support, less stability in the pelvis, which might mean pelvic floor tissue themselves, my pelvic floor muscles might be weaker. They shrink away a little bit. They're a little more sensitive and irritable, but it can also relate to how much stability we have in our pelvis itself. Also, as a result, if we have less pelvic floor support. So do we know that typically that estrogen helps support a pelvic floor and a pelvis? Yes, because I can even visually see, if I see somebody first with poor levels of estrogen, that their tissues look irritated and thin. And after some use of estrogen, which typically these days is vaginal estrogen cream, that things are a little more plump and supported and less irritable looking. Yes. That's not to say that everybody can do well on estrogen or that everybody needs estrogen. But if we were to kind of look across the board at does estrogen affect the pelvic floor and affect sometimes pain in that regard? Yes. The other big factor in pelvic pain too, as I mentioned briefly, was sex. And when we have low estrogen, vaginal tissues are very irritable as well. So it doesn't relate just to the stability of the pelvis, but also the sensitivity in the pelvic floor muscles. And more estrogen helps soothe that area, give more natural lubrication, and decrease pain in that regard as well, typically.
So just on that, and then there's another good question in the chat. Is there a male sort of counterpart to the hormone discussion?
There's not as much well known, I'll say, in that area, because I think kind of for years pelvic floor treatment was focused more on women, but definitely, and I've seen men who I had a client that started using testosterone a bit just for his own general health and was getting a little bit of adjunctive testosterone, and he started increasing pelvic pain and came to me for that treatment as well. So definitely when there's a flux in hormones, male or female, does it change things? It does.
Okay, that's very interesting. Ruby has said she thanks you, and she's definitely looking into the pain clinic application. And I'm just going to ask Celine to include the link to the USAS. Yeah, she's going to include the link in the email that you'll get after the session today.
Perfect.
It's amazing clinic, and they do amazing work there. I would agree. Tina, she's the children's librarian. She has asked a question. What about coming on or off GnRH agonists and analogs? That's a scientific question.
Yeah, this is the problem. I don't want to call it a problem, but the fine tuning of what mix we need to do to find balance. And are we coming on? Are we stabilizing? Are we coming off? Again, any flux in anything can cause a change. And I don't want to say that it's going to cause pain specifically, right? But it's going to change how pain is interpreted as well. So, yeah, that's a tricky question, Tina, because of all the factors involved in the medications.
So just for my information, can you tell me the GnRH, what that acronym is for?
Are you asking Tina? Tina, do you want to discuss?
Or Bree, you could as well if you. I'm asking because I don't know what the acronym stands for. Or maybe Tina, you can come on and tell me. You can unmute yourself. or anyone else who might know what that is. But one new message. Gonadotrophin releasing hormone. Thank you, Susan Tupper. Susan is kind of acting like she just made that up, but I think she's probably right.
I made it up thanks to Dr. Google, who answered my question quickly.
Excellent. Thank you. Thank you. Okay, and we've got a very nice note here from Sasha, who you'll see. Sasha's seen Bree many times at Craven Sports Services. I've suffered from back pain since I was 16 and have had 2 spine surgeries. She helped me more than any other practitioner, and her enthusiasm and general care is palpable. She's going to check out the clinic. That's a very nice testimonial, Sasha. Thank you so much for sharing that. And I would, I've always found Bree to be very authentically enthusiastic and genuine in her care. So, yeah.
Thank you. That's awesome.
Do we have any other questions that anyone has? You can put them in the chat, or you can do this, or you can do an interpretive dance. Susan Tupper's gonna. You're not doing interpretive dance, Susan? Okay. So Susan asked, do pain meds like opioids, antidepressants, and gabapentin also affect hormones?
Oh, this is a good question. We do find that there's definitely, kind of in relation to what Tina was asking too, that when there's pharmacologic, I'm going to call it, just to kind of give it a broad spectrum, that there is either side effects or sometimes interactions between them. So part of it relates to the pain cycle and how our brain interprets pain, and then how our body reacts to the pain. And oftentimes when I see people, they're on a cocktail, is the only probably word for it, of medications that have interactions, which sometimes are really good, but also that can cause a change in things. And, you know, I don't know that you can always say that this medication might affect hormones in this way, but I think very often we see that there's a reaction to the body. And, you know, I think it's hard because we try to treat a source of the pain, but it's not always that source of the pain that continues to be the problem with the pain, right? And that's when we kind of start chasing it with other medications and trying to help it. And sometimes, honestly, it's when we pull down some of the medications that we see, when we can kind of clear out some of the side effects and the interactions, that's when we can actually get a better picture of the pain and treat it more specifically. But it's hard because when you have one issue and you have a medication that might create a second side effect, and then you treat that with a different medication, and then before you know it, you have, again, a cocktail that you're just chasing.
And that's got to be challenging to figure out what the pain level is actually at, because you're worried about withdrawing medication because you don't want people to be uncomfortable. So that's a real balance. Yeah,
absolutely. And who wants to risk ever increasing their pain? So it's definitely a fine dance of, we could maybe tweak this without risking something else having a different side effect or a different change to it. Yeah.
That's a great discussion. Thanks, Susan, for that question. That was great. I don't see any other questions, but we're not done yet, but we're going to move on to our next speaker. Thank you so much again, Bree, for your presentation and for your insights to the questions and for the discussion. Really great.
Thank you. It's
now my great pleasure to introduce you to our next speaker today, Laura Millions-Cohn. Give us a little wave there, Laura. There she is. Laura grew up in rural Saskatchewan, loving athletics, reading, and socializing. As a young adult, she fell in love with working with special needs children and built 2 successful businesses. Eventually, her pain forced her to walk away from all of that. Laura began experiencing severe symptoms of pelvic pain at just 12 years of age. Her poorly treated endometriosis and pelvic dysfunction had left her on full-time disability. After living through dismissive doctors, botched surgeries, and mistreated conditions, she quickly realized that she could use her voice, and in bracket, her very loud voice. I've never heard Laura be very loud, but I know she's a great advocate. She used her voice to try and help improve endometriosis and pelvic care for people in Saskatchewan. In 2013, Laura helped found the Facebook support group Saskatchewan Pelvic Pain and Endometriosis Warriors. and since then has been telling her story to promote self-advocacy and demand for better care provincially and beyond. Laura lives in Saskatoon with her husband and her dog, her two amazing caregivers. So I'll invite Laura, I'll put myself on mute and invite you to start your sharing your experience.
Thank you so much, Cathy. I'm really honored to be here today. Can everybody hear me okay? Okay. So I wrote everything down. Otherwise, I also ramble. There seems to be a rambling problem in this group. But I know it's because we're all passionate. So, as mentioned, I'm Laura, and I live with severe chronic pelvic pain and dysfunction as a result of my myriad of conditions and diseases. I won't go into detail on every issue today, otherwise we'd be here forever. But to start off the bat, in the hopes that someone listening will feel less alone, I figured I'd just list them off. So I either have or have struggled with, drumroll, severe endometriosis, severe adenomyosis, masses of adhesions and scar tissue, interstitial cystitis, degeneration and impingement and arthritis in both hips requiring surgeries, as well as my low back, severe hemorrhoids, and then nerve damage issues like pudendal neuralgia, piriformis syndrome, levitator syndrome, and of course, central nerve sensitization that goes on to cause further issues like chronic migraines. So when I say I struggle with pelvic pain, I'm not lying. Oh, and can't forget about doctor-induced PTSD. My issues began when I was about 12 years old, right when my period began. I didn't get to be excited about womanhood because suddenly, seemingly out of nowhere, a monster awoke in my belly. Each month, this monster got stronger and more enraged. And as each month went on, my menstruation issues compounded. Now I wasn't bleeding myself literally into anemia for a week, but 2 weeks, and then 3, and finally into 28 days a month. During these times, I was passing out from the pain. I was bleeding through an extra heavy tampon and 2 bedtime pads that I would make into a saddle. I started shedding clots the size of my hand. I smelled like iron. My digestive system was heavily affected, and I would have horribly painful bowel movements, like daggers in the rectum and through my belly. I was so alone, and I felt like every woman around me was handling their periods so much better than I was. My mother and I didn't talk about periods, so I didn't talk about it. It didn't even occur to me that this was irregular until it got to the point of bleeding all but 4 days a month. But even still, I didn't talk to my peers or even my mom. I first brought it up to my doctor in shame. I was immediately put on birth control. I was 13 years old. At first, it was a regular monthly dose, but of course my period, who would come to be named Linda, broke that mold. So we changed to dosing for 3 months at a time, and that worked for a while too. Before I was out of high school, I had tried a few different birth controls, and that became the norm over the next decade or so. I would switch and one would work for a time before I would inevitably have to change, either because it would lose effectiveness or I couldn't manage the side effects. Birth control was the fix until it became evident it was just the Band-Aid trying to hold my broken insides together. My doctor retired, so when it became clear that something was wrong and it wasn't just my period working itself out, as I was told, I asked his replacement to look into it. I was labeled a hysterical woman, a hypochondriac who was complaining about her period. I spent month after month in the ER, treated for excruciating pain caused by gas. Thankfully, I knew something was wrong, and I stood up for myself. I tried a few more doctors before I found someone who would listen to me. I will never forget when she told me, "I don't know what's wrong, but we'll figure it out together." Those words gave me hope and saved my life. They got me through the next year or so of tests for everything under the sun, until we got to the point where it seemed like endometriosis was the culprit. I got referred to a gynecologist when I was 19. I'll never forget the first time we met. She was quite sure from the evidence that I had endometriosis, and her first suggestion to me for treatment was that I could get pregnant because the symptoms stop after pregnancy. Thankfully, I decided on the more scientific front of getting an ablation laparoscopy, and they found endo on my stomach, abdominal walls, and ovarian cysts. I had a reason for the pain. I had a fix, and the hell was over. I was free. For about 3 months, I experienced a normal period before the pain and symptoms came rushing back. In my world, there were no treatments other than birth control management because I was seeing what I was told was a specialist, and I expected that so-called specialist to know what was best for my disease. But this specialist couldn't treat me. My disease was too advanced, and a gynecologist is not a specialist in pelvic disease or excision. I asked her to refer me, so she referred me to an actual specialist. But this specialist was just a regular gynae who had been working longer, and all they could do was another ablation and hopefully get it all. They didn't, and now I was getting less than a month pain-free post-surgery before it started up again. 24 hours a day, 7 days a week. Being on birth control became useless, and I knew I needed to step up for myself to find better care, because the information I was bringing to my doctors and surgeons about excision surgery was beyond their expertise. I tried to get referred to Ontario, to British Columbia. I believe that at the time, we had 4, maybe 5 doctors listed on the letter as specialist options in Canada. But in fact, at the time, the BC Women's Centre was only seeing interprovincially, so that took 2 doctors off the list. I know that well because I waited on that list for over a year before I was told. Somehow I found Dr. Teal, likely through a Facebook group, sadly. I mean, thankfully, but sadly. But he and the other docs had a wait list of over 2 years. At this point in time, I was getting closer and closer to my worst point of being almost completely bedridden. Then I couldn't wait anymore. I was so constantly seized by pain and spasms that I looked like a Parkinson's patient. So my dad took out a second mortgage on his home, and we went to the Center for Endometriosis Care in Atlanta for a true excision surgery. My doctor couldn't believe that they had actually done a laparotomy, opening me up in my last surgery, and that they still missed obvious endo. My pelvis was obliterated again, which means your entire pelvis is stuck together with adhesions and scar tissue, and then they have to pull it all apart and put it back where it should be. This was the first time that I had heard that term, though. He found bowel disease that he said had obviously been sitting there for years, stating that he would call it malpractice if he knew that the doctors simply didn't know better. My uterus was huge and misshapen with adenomyosis. There was no saving it. We left a half an ovary in the hopes that I wouldn't have to go through menopause so young. I was 28. But of course, my endo came back within a year, something that astounded my doctor, and I had to have it removed with one more excision surgery. That was in 2015. Since then, I've had surgery on both hips and my low back, as well as my recent hemorrhoidectomy. Every 3 months, I go in for nerve block injections. We use a mixture of caudal epidurals and lower ganglion nerve block injections from my pain specialist. About every 3 months, I also get pelvic floor Botox injections and abdominal trigger point injections. My diaphragm is stuck to my liver still. I've had a long relationship with opioids and medications, and a future without pain medications, which I had once wished for, now seems unlikely. Every week I am busy going to medical appointments or treatments and mental health appointments. I'm a mess, and most of the time I feel like one. The hardest thing about all of this is that if I had only been treated better earlier, things could have been different. I see patients who get in with the right doctor right away. I'm not saying that they don't struggle, but their struggles with the right doctors and treatments often go side by side with things like having a family, getting an education, having a career. While I try to hold on to hope, I'm not sure if my pain will ever leave enough room for things like that. I don't know what my future may be, but it can be hard not to forget that I'm in this position because the knowledge simply wasn't here yet, and because of sexist doctors who think they know better. My day-to-day experiences range from pitiful to downright boring. In 2014, I was forced to step away from my successful business working with children with special needs. I thought that it would be just a year, maybe two, and I'd be back at work. I can't believe that I'm coming up on a decade of not working. Although I know that's not a fair statement to myself because I am working. I have spent the better part of my tenure as a patient advocating for the pelvic pain community in Saskatchewan with the Facebook group Saskatchewan Pelvic Pain and Endometriosis Warriors. I live each day using the spoon theory, with each day dictating how much energy one thing or another will expend. Some days, getting up and going in the morning takes most of my energy for the day. Some days I have more energy, or it gets a chance to recharge in one way or another. While the 1 to 10 number scale is basically baloney in a lot of ways, to give perspective, each day I'm starting the day with a minimum of about 4 on the pain scale. Usually by the end of the day, I'm experiencing about a 6 to 7. Many days are worse, or have moments that are worse, leaving me unable to sit up straight and brush my hair, or unable to sit squarely on my bottom, or to stand up for too long. A task as simple as a slow walk with my dog is unmanageable most days. I get nerve pain that sears me like fire, stabs me like knives, pounds me like fists, or feels so intense that it seems something must break or burst. This encourages muscle spasms to spread, so bad that I need my husband to carefully uncurl my twisted body. My pelvis is unstable and weak while holding incredible tension, which causes issues across the entire body. It's exhausting just to think on which details to include today. But despite the challenges, I try to keep fighting. I go to my appointments and treatments each week. I take just about every pain course and mental health course I can manage to. There are many great resources here if you look for them. I have tried every medical and holistic pain and health treatment available to me over the years. I advocate. I try to find energy to focus on my own joy, which is hard, but I know how important it is. Because pain gets to a point where it just affects everything. It affects how I eat, sleep, move, how I go to the washroom, how I take in and remember information and events. It affects my marriage and my relationships. I'm far from the Laura that I wish I could be for them and myself. It, of course, affects my sex life. I had to stop playing sports, and it's hard to be an athlete without a sport. It can shake my life so deeply that I just decide to give up on a day or a week, or even try to write off and forget the last year of this fragile, beautiful life. I'm so numbed by pain and meds that I don't want to read and write anymore, two of my favorite things. It hurts to sing, that causes spasms, so that's out too. Some days it hurts to hope. It can seem endless, but I try and remember that it's not. Because if nothing else, pain reminds you that you're alive. And that reminder begets hope for a better next day, or a better next hour, or next moment. And I try to take that hope and hold every bit of it, to let it nourish me and re-energize me, to let it give me even one more spoon, so I can get one more spoonful out of my day. Some days I take that hope and dash it myself, trying to crumble it into pieces because it would be easier to live without it. But in the end, that's not how I want to live. That's the end of my story. And now I'm going to answer 2 questions. So the first is, what's been the most helpful for me in managing my pain? And has that changed over time? For me, it's impossible to list only one thing that has helped with my pain. I would say that my top lifesavers are mindfulness, therapy, cannabis, getting on the right meds, like using the medication assessment center, pelvic floor physio and regular physiotherapy, and the pelvic floor Botox injections, baclofen suppositories, and making sure to manage my bowel care. Having things that bring me joy each day is probably the most important thing. I took up bird watching because worst case scenario, I can do it standing from my kitchen window. My relationship with meds and some treatments has changed over time. because while I find more treatments and more day-to-day management, I don't need nearly the amount of meds that I used to. I remember when I first met Dr. Teal, I was so nervous I would finally go on to opioids. I figured that my life would be over for some reason. But I recall him saying something along the lines of, "We need to reduce your pain while we find ways to manage the source." Really, it wasn't the drugs that would interfere, because the pain already was. Also, I can get away with a lot more these days with less pelvic floor physio. When I first started, I was going 2 times a week, and now I go in when I can afford it, which isn't that often. I do wish I could go more, but we desperately need more pelvic floor physiotherapists who are trained in pain, practicing in the public setting. And the final question, what's one piece of advice you've received that's made a difference in your life, or understanding about pain? It's tough to choose one piece of advice that's made a difference, but I would say that learning about the spoon theory on using energy made a really big difference for me. So I'll give a quick how do you do for those who don't know about it. The spoon theory was made up by a patient with lupus who was trying to explain her condition to a friend. Basically, we are all given a finite number of spoons of energy to expend in a day. The day that she came up with it, they were sitting in a diner. If you had a quiet day yesterday, you may have spoons left over giving you extra, like 14. Or if you had a big day yesterday, you're going into the day with a deficit, let's say 9 spoons. Oh, I think I forgot to say, let's say for now that everyone has 12 spoons to spend for a day. Now, we all have to get through our day spending our allotted spoons. So I had a lousy sleep, so I'm coming into the day -1. For Bree, it takes a half hour of a spoon, or it takes a half of a spoon to shower. But because I have chronic pain, it takes me 2. This is just an example. I'm not putting numbers on Bree. Next, we want to walk the dog. For Bree, it takes 1.5 spoons. For me, it takes 4.5. We still have a whole day to get through, so I need to decide, do I have the spoons for the day to take my dog for a walk? Preparing and eating food? For Bree, that's 2. For me, it's closer to 4. Well, I'm doing this podcast today, which is going to take 3 of my spoons. So I don't have enough to walk the dog. Then I have to do my physio. That's 3 spoons too. Now, out of my 12 spoons, I've used 9, and we're still at 3 o'clock. Now I need to weigh how and when I use my spoons, because I can only run on a deficit for a few days before things become untenable. So each day I plan out my spoons, and that helps keep my life manageable. It also really helps when I'm explaining my pain to others. It helps them understand clearly. All of the people in my life know that I'm a spoonie, and when they call me up to invite, you have the spoons. Or I can say, I don't have the spoons, and I don't have to explain it myself, go into details of why. It takes off a lot of pressure. That's me. That's me.
Thank you so much, Laura. You certainly have endured much since really before you were a teenager. I really like your description of the techniques that you use to describe your process for finding joy. And I've never heard the spoon theory before, but I really appreciate that you get that visual and it puts you in control of your spoons and how you make decisions about how you pace yourself during a day or during a week. I found that really, really helpful. I know your advocacy work is really important and is impacting others in a very positive way. And I can't imagine it's not making a difference for other people in the province. And you may say you're a mess, but in fact, to me, you're quite an inspiration in terms of what you've been through and how you've turned that into helping other people understand how they can maybe use some of those techniques to find their joy or improve their situation in a day. So I really appreciate you sharing your experience with us today. Thank you so much.
Thank you, Cathy. You're welcome. Just to mention, actually, on the spoon theory, I forgot to say, there are some, like, you can just Google it, and there's some really great, like, you can just print off a page or maybe a couple pages, and so that you can literally write down the things that you're doing and kind of put a cost to them to help plan out your day. So, and thank you, Cathy. That's very nice of you to say.
Laura, I'm going to invite you to open the chat because there are some people on the session that have shared some words for you and for how you're helping them feel like they're not alone in their own chronic pain journey. So I invite you to read that. And Sasha, how do you determine how many spoons you start with? I think you said, Laura, that you start with an arbitrary number 12 in a day, and you decide what 12 means and what 1 means and what,
Yeah, it's really flexible and personalizable.
I love that technique. I've never heard that one before, but I really appreciate that.
What I would suggest for, like, you know, determining those spoons, especially like for your baseline, list the things that you need to do every day. So you know, every day I need to shower before work, and I need to make breakfast and get supper started, whatever. Like, list the things that you're doing. Getting dressed, like, for some people, getting dressed takes no spoons. For some of us, that takes a spoon or maybe 3 on a bad day, whatever your number is. But go through your basic day and kind of, that's a good way to figure out the number that works for you.
That's excellent. Thank you. Thank you so much for that. And thank you to Bree and Laura for sharing their time, expertise, and insights with us today. And a big thank you also to everyone who was on the session today. Really important one. Just a few closing comments. The recordings of the webinars will be available on the SaskPain website and the SaskPain YouTube channel. The link to these will be shared with you by email after they're ready to go. An email will be sent out to you tomorrow with a link to an evaluation. And thank you so much in advance for completing the evaluation and providing your feedback. It really helps with planning. And also Celine will attach the link to the USAS Chronic Pain Clinic. Our next webinar is scheduled for next week, Tuesday, May 24th at 6:30 p.m. And I want to make sure I got that time right, Celine. Yeah, 6:30 p.m. And the theme for the webinar is neuropathic or nerve pain with Jackie Krauschauer. She's a rehab doctor situated in Regina. We will also have another art therapy session with Dana. I'm really enjoying these art therapy sessions because I'm not artistic at all, but Dana doesn't seem to mind that I'm not artistic. Please share information about this webinar with your family, friends, and anyone that you think may be interested in joining us. And again, thank you again to Bree and Laura, and thank you for your attendance today. See you next week.